right, so these are your learning objectives. Okay. Let me tell you again, if you go back to my knowledge check from asthma and you compare the same thing, if you do have the blueprint of my exam, there is only so many ways I can ask the same question. So the question paper is out. What it means is the things which you can see in knowledge check and your learning objectives more or less will get repeated in your exam as well. So please do some favor for yourself and for me, that understand the concept and see, like, just don't rush through the slides. I don't have time limitation, but you don't have it. You take it back to your dormitory, to your home, read through it. You have questions, you come and see me. I presume science and clinical, there are 20 questions again from COPD for science, 20 for clinical, and I think the 10 would be from tobacco cessation, depending on how much. So you still will have 20% questions, or 20%, like 20 questions, which is probably going to be like 40% of your grade, hopefully, for your exam. All right, so here learning objectives. We are talking about inflammatory process, chronic obstructive inflammatory disease, basically coins from the term called as inflammation. There's chronic inflammation for a long period of time. There are cellular and mechanisms which you will be responsible for, especially the structural cells. As we discussed in the last class, for asthma, structural changes basically mean subepithelial fibrosis, mucus hypersecretion. These things keep coming. Okay, so we are not going to go back and read how that is happening. We know the mechanism of subepithelial fibrosis. We know the mechanism of hypertrophy. We know the mechanism of hyperplasia, right? So that's all we're going to talk about here. Differential diagnosis, identify the main differences, how COPD is different from asthma. That is going to be one of a couple of questions in the exam for you guys to know how you diagnose asthma versus a COPD patient. And then the pharmacology is basically the mechanisms for a lot of drugs. This pharmacology is like 10 minutes. The last 10 minutes, if we have in the class, we can just breeze through it. You're not learning anything new. The same drugs, the same photos, the same pictures, everything is same. The mechanism of a drug doesn't differentiate if you're using the drug for an asthma patient versus COPD. You understand? The mechanism still says the same. What it means is, if you've mastered the drugs from asthma, you are not spending more than 10 minutes, which we will do the same justice in the class today, that the last 10 minutes is only the mechanism of the drugs. Okay? So this is already taken care of, except like one drug which we're going to read, which is different from what we saw in asthma. We spend the majority of our time in the first three. Take some time, understand what I'm trying to convey here, and if you have questions, then please raise the hand. Moving forward, COPD definition. It's a heterogeneous condition. It affects your airways and alveoli. You see those things here highlighted in yellow. That are the key words you have to always remember and hold in your head as you start building this foundation. So it affects your airways and alveoli. Alveoli is basically in your bronchial, the tertiary bronchioles. What happens in your tertiary bronchioles? We have your alveolar buds, right? And what is alveolar responsible for? Another one, gas exchange. If your alveoli is damaged, okay, your gas exchange is going to be impaired. Keep that in mind. Your alveoli is damaged, your gas exchange is impaired. Gas exchange is impaired in sense oxygen carbon dioxide interchange doesn't happen. Your body is having less oxygen, because that's what's going to happen. If we have more oxygen, are we complaining? Only problem is when we have less oxygen is when we complain. So when we have less oxygen, what is higher than? Carbon dioxide. We have more carbon dioxide. We lead a condition called as hypercapnia and hypoxemia. Hypercapnia is increased carbon dioxide levels. Hypoxemia is decreased oxygen levels in the blood. Okay, this is coming from your biomed pharmacology. Okay, we discussed these two terms, and this is acidosis. So all those things will be affected. I'm telling you the implications of what will happen if your alveoli is damaged. And who's damaging the alveoli? It's our lifestyle. People may be born with a genetic disease. We're going to talk about that, who end up getting a COPD. But for the most part, it's your lifestyle. Okay, which ends up, and who's one of the most important? We're going to talk about that in a bit. Symptoms: dyspnea. What is dyspnea? Shortness of breath, cough, and sputum. So these guys who basically have a diagnosis of COPD will be having persistent cough. It's a cough which is not like, it looks like a normal a cough with mucus. It's very dry cough and it's going to be very persistent for a long period of time. Dyspnea, shortness of breath, and sputum production to some extent. And then we have progressive airflow obstruction, which is a hallmark feature of this disease. You cannot forget this. The only way you can differentiate asthma versus COPD is this aspect of airflow limitation. Okay, you gotta remember that keyword, airflow limitation. The same thing again in so many words. So we talked about, we are breaking this down now, heterogeneous lung condition characterized by chronic symptoms like dyspnea, cough, sputum production. Did we discuss anything different? We are just repeating the same thing so far. And abnormalities of your airway and alveoli causing persistent progressive airflow obstruction. This comprehensive definition comes from the GOLD 2023 guidelines, which Dr. Crispy will touch a bit when he starts his class about what those guidelines really entail towards. And then things to remember on this. Very, very important. Highlight in red, yellow, blue, whatever color you like. You cannot forget this. This is the most distinct factor for COPD. Airway level, which is chronic bronchitis, alveolar level, which is emphysema. So COPD is a combination of two diseases. One is chronic bronchitis, the other one is emphysema. What is bronchitis? Itis is inflammation, bronchi is inflammation of bronchi. Okay, so that's easy. But here we also have at the alveolar level, which is basically a structural changes. So a person who takes or smokes a lot of cigarette, he's intaking all those the irritants of the which is present in the cigarette, and it's going to go and structurally damage your alveoli. So alveoli is the place where gas exchange takes place. There's no more gas exchange. It can lead to a condition called as emphysema. These are the two things. We are going to keep repeating this a million times now as we move forward. So just two things you have to always remember, which leads to impaired gas exchange, as I told you, and a reduced lung function. Are we good? So far, what did we discuss? We discussed that COPD is a heterogeneous lung condition. Okay, airflow limitation, keyword. Chronic bronchitis, another keyword. Emphysema, another keyword. If you can hold this three, we move forward. Can you hold this in your head? All right. So talking about the risk factors, as I told you, who is one of the primary risk factors? Can anyone name me? Name that for me. Smoking. 80 to 90% of the cases which are diagnosed with COPD tend to have a common denominator, which is smoking. So smoking is basically the primary causative factor, and again, cumulative exposure over a long period of time also speaks to its severity. So the more time a person is getting exposed to it, whether passive or active, especially with the cumulative exposure, can talk to its severity. Infections. This is again not in your control, but in case if people who have chronic infections and childhood respiratory illnesses, they seem to have vulnerability. Again, how much of that is true? The statistics doesn't talk a lot about it, because we are basically COPD, as I understand, it is at the grassroots level of your alveoli, where someone is going and always hitting it. Your body doesn't like it, but you're still smoking a cigarette, and those irritants of the cigarette are going and destroying the alveoli. That's how a COPD is caused. But there are factors which can also compound the effect of that, and one of them would be the childhood respiratory illness and chronic infections. Moving forward, environmental occupational exposure. If you are working in an environment where you are exposed to biomass, occupational dust and chemicals, and outdoor air pollutants, you end up having a higher COPD chances. And then this is a genetic predisposition, alpha-1 antitrypsin deficiency. You got to remember this. Just one genetic factor, alpha-1 antitrypsin. You'll know the significance of this enzyme when we talk more. But at this time, just remember that this is the enzyme responsible. If a person doesn't have this, he ends up more prone or more vulnerable to COPD. I never will use a term called as a person having genetic deficiency, and you as well. When you're working on your clinical sites, as you're becoming proficient pharmacists and researchers, and always there is no cause and effect. There is increased propensity, increased vulnerability, increased probability, increased susceptibility, increased, you got to use that terminology. You cannot directly say that a person having alpha-antitrypsin deficiency will end up having a COPD. No, it increases the chance. Always use that. So sometimes you're not really in a spot where you have to defend it very, very strongly. because there is a lot of evidence which can go against it as well. All right, good. As I told you, there were two important aspects of COPD. One was chronic bronchitis, the other one was emphysema. Chronic bronchitis, emphysema. Chronic bronchitis is basically it's a progressive chronic lung disease. As you can see, it gets repeated by itself, persistent airflow limitation, small airway disease. We're not really going into the weeds of understanding what does airflow limitation really mean. It's not fully reversible. One of the things which you have to remember from asthma versus COPD is irreversible. When your parenchyma of your lungs get destroyed, your body will repair it in such a way that every time a tissue gets damaged, will you get the same kind of tissue? You get a tissue which is more rugged. So what happens is, this is the beauty of your body. You have your body, you keep exposing it to tobacco, to smoke, to something which is not good for your lungs. What happens? Your lungs will now understand that, okay, whatever that tissue is made up of epithelial cells, they is no longer be able to resist the exposure. We will make a tissue which is more resistant to it. And in the scope of making those tissues, that tissues have a lot of different morphology. Having a different morphology means having a different functional characteristics of that particular tissue. So that becomes compromised. So you got to understand that your body is trying to help you. In the context of helping you, it is losing what it has to basically do for you. One classic example is epithelial tissues, which every one of us has. They have good elastic recoil. Means you stretch them, especially you see the lungs, like if you go to some of the butchery shops, their lungs for lamb, goat, okay, you can see how the lungs look like. So it's mostly stretching. There is a reason for that. But if you repair the tissue for epithelial, which our body does it, when you keep exposing it, the tissue is damaged, your body will replace with new tissue, which is not epithelial anymore. It is a different tissue. It is columnar squamous epithelial cells. Okay, so that tissue will lose the elastic recoil capacity. It is no longer elastic. If your lungs are not getting elastic, it's not expanding or it's not contracting, expanding and contracting, it leads to less air coming in, less air going out, leading to a condition of less gas exchange, airflow limitation, hypoxemia, hypercapnia. That's where we end up. That's your end outcome. If you know the end outcome, you know the formula, that's how you have to come to that. Max, it's similar to max. Okay, so math, how you do it, you know what the result should be, so you work your solution towards it. So for a COPD patient, the end outcome is finally going to be hypoxemia and hypercapnia. There is gas exchange. Before gas exchange, there should be structural damage of your alveoli. Before structural damage of alveoli, there should be exposure. Before exposure, you should be working in that environment. Okay, all of that adds up to finally lead to that irreversible chronic obstructive pulmonary disease. Go ahead.
It sounds like this situation will be the same for somebody who has chronic asthma.
Mm-hmm.
So can we say chronic asthma equals COPD?
No. COPD has two conditions. You missed the first part of the class when you came late. So there is chronic asthma and there is also emphysema. Okay, I can tell you that COPD is equal to chronic bronchitis plus emphysema. Then you are correct. It's just not one. Because chronic bronchitis is similar to an asthma condition as well. Because in asthma also what happens? Mucus hypersecretion, airway remodeling, it's similar. The only differential over here is your emphysema component. If you add that emphysema, then COPD differentiates from asthma. If you add an irreversible component, COPD differentiates from asthma. If you can remember those two things, that's the most important differentials. Are we all good? Can we move forward? It's a good transition for what Kingsley mentioned. COPD often includes chronic bronchitis and emphysema. I have put, what does it mean? Bronchitis is airway inflammation and mucus hypersecretion. Is it new for any one of you? Did we hear this earlier? Mucus hypersecretion. Yes? Where? Infectious diseases? No, asthma, right? Just check it. And emphysema is destruction of your alveolar walls. Okay, are we all good? Did I convince you enough that COPD is a combination of chronic bronchitis and emphysema? We are only going to talk about this on every slide. Okay, that's all is your chapter. If you understood this, you can leave. Okay, some students want to stay back, can stay back. But that's all we're going to talk about as we move forward. Here we have a knowledge check. These questions are only going to get twisted and turned and asked in the exam. Take some time and read through it and answer the questions. A clinician is counseling a patient who is a 60-year-old female smoker with a childhood pneumonia, a family history of COPD, and a recent job exposure to chemical fumes. What are we talking about? All of this. Risk factors, right? We have a childhood disease. We discussed about that. We discussed about the place where he works, or she works, sorry. Which risk factors should be considered most strongly associated with COPD? Someone disagree with smoking? Can we move forward? A 70-year-old former coal miner presents with chronic cough, dyspnea, and sputum production. What is it telling us? It can be asthma or COPD. Okay, let's move forward. Spirometry confirms persistent airflow limitation. What is airflow limitation? I told you. Yeah, so those keywords, you're gonna not forget it. I am not different from any one of you. The only difference for me is I read this slide 10 times before coming to the class. What it means is airflow limitation is something which is stuck in me. I'm gonna hold that. Okay. Based on the definition of COPD from gold guidelines, which combination of pathological changes best explains his condition? Reversible bronchospasm. Is this a disease which is reversible? You're not like you cannot get back your alveoli, which is already lost. Bronchial hyperreactivity and eosinophilic inflammation. What is this disease then? What is the second disease telling us? It's asthma. Are you able to understand now? It's eosinophils, it's interleukins. We're not talking about inflammatory mediators specifically. We're talking about structural damage. COPD is most of a structural damage. Asthma is more of an inflammatory disease. Okay. Bronchial narrowing with emphysematous alveolar destruction. Okay. Airway edema with mast cell degranulation. What is airway edema and mast cell degranulation? What is this disease? Getting it? Okay. So answer is, you're telling the answer now. I'm going to ask the same question in the exam in a different way. Okay. Please answer to that as well. Okay. In COPD, a small airway, I can't take this. In COPD, the small airway fibrosis and alveolar wall destruction are hallmark changes. As we discussed about it, there's alveoli and there is fibrosis. Which of the following best explain the combined structural and inflammatory changes at the cellular level? Eosinophilic inflammation. As soon as you think about eosinophils, you think about asthma, right? That's how you eliminate the choice. We're not talking about it anymore. And then it also talks about reversible, which is not correct. Chronic inflammation induced macrophage activation. Macrophage activation.
That's also asthma.
This completely changed. I can't read from here. Where were we? This one?
Yes.
Okay. Which of the following best explains combined structural changes and inflammatory changes at cellular level? So we have eosinophilic, that's not right. Chronic inflammation induced macrophage activation, leading to elastin degradation. We didn't discuss this enough, but I told you one point. Remember, the elasticity is getting compromised. We're gonna go into the cellular mechanism. It's too early to ask you, but I'm just gonna throw this at you so that you keep that in mind. At the structural level, your macrophages are getting activated and there is loss of elastic recoil. And that's when the elastic degradation comes to place. Okay? So hold that. Goblet cell hyperplasia. What is this talking to? Mast cell degranulation. What is this? So what is the only thing which can speak to it? Sorry. All right. Sorry about that. It just took the second option as well. So let's read this last question. A patient with COPD demonstrated reduced oxygen diffusion capacity and hyperinflation. Which cellular and structural processes best explain these findings? So we are primarily genetic with no modifiable factors, explosive related to childhood infections, or multifactorial involved environmental, genetic, and developmental. It will always be all. When you talk about risk factors and you find like an option where there is talking about there is no 1:1 correlation in any of these diseases. There's always going to be multiple risk factors. So if you find that on the option, that's how you take your test. Even in your applets, they talk about risk factors and you find like an option which is multifactorial, 99 out of 100 times, that's the answer. Because we haven't got to that extent where we can blame one risk factor for your disease. We have multiple of them. So definitely that should be the answer. And then the last one is solely occupational due to current job exposure. It's not going to be solely. That's a very strong statement. Okay, it's not just because of your occupational. It can have genetic component to it, which made you vulnerable to be in the place, like which made you vulnerable not to fight the problem when you're at that job workplace with that exposure. Okay, are we good? Moving forward, we're talking about three important aspects over here. So we discussed about structural changes. We talked about inflammation. Let's see how a structural change is going to happen and how that inflammation is kicking in. So normally we're talking about a step-by-step process, 1, 2, and 3. That's how you have to remember. If it's not on the slide, go ahead and write down step 1, step 2, and step 3. And this is in the context of mostly of the first issue, the chronic bronchitis. Okay. Step 1. A person gets exposed to cigarette smoke or air pollution, it triggers an inflammatory response. Yes, in the airways, initiating the process. Okay. Step 2. As soon as he takes anything inside, your body doesn't like it. Yes or no? But we still smoke cigarette. So those people who smoke cigarette out there, just inform them that you're basically throwing something inside your body which your body doesn't like. And what does it do? It defends it. And how does it defend? It activates the immune system. Immune system is all about inflammatory mediators. So basically, immune system kicks in, it recruits inflammatory cells, which are neutrophils, macrophages, lymphocytes to the airways, and this causes release of inflammatory mediators. So far, this is similar to asthma. The only thing which we have to remember for COPD is highlight in red, color blue, yellow, whatever you like, this enzyme release as well. That is a distinct factor for COPD to differentiate from asthma. Okay, we're not also talking about an enzyme which is neutrophil elastase. If you want to put it in the bracket, write down the name of the enzyme, NE. N as in Nancy, E as in echo. Neutrophil elastase. Elastase means elastic. Elastase are the enzymes responsible for breaking elastic. And what is elastic? Elastic component in your lung, elastic recoil. So this enzyme will be released, it reduces or breaks the elastic recoil capacity, leading to less expansion and less contraction. Less expansion means less air coming in, less contraction means less carbon dioxide going out. Carbon dioxide stays in, oxygen doesn't come in, leads to a condition called, again, what is our end outcome? Where are we getting at? Hypoxemia, hypercapnia. Hypoxemia, that's where you have to get in. Whatever story you will tell, you will finally have to convince them that that is where we have to end with a COPD. Are we clear? Okay. And then all this enzymes gets released, it causes tissue damage and remodeling. Okay. What is the different aspect over here? The enzyme for COPD. This inflammatory process over a period of time keeps continuing, causing structural changes, smooth muscle hypertrophy, subepithelial fibrosis, mucous hypersecretion. Did you hear all these terms earlier? Asthma, asthma, asthma. Structural changes also to some extent in asthma. Yes or no? But this is all inflammation to airways, lung tissues over a period of time. All good? Going forward. Here we have to take some time to understand the two things. We discussed the two important hallmark features of COPD. What are they? Chronic bronchitis, emphysema. Chronic bronchitis, the first thing you have to come to your mind is, this is basically your clinical diagnosis. A patient comes to your clinic and you're trying to differentiate between asthma and COPD. The first thing you have to watch is chronic bronchitis. And in chronic bronchitis, you're looking at chronic cough and phlegm. So you should be having that. What is this? Chronic cough and phlegm. It is a way to tell that your body is basically struggling inside because of the exposure. It can be an infection, but infection doesn't end up leading to a COPD. Okay, it's more than that. Airflow inflammation, as we already discussed, so your body gets exposed to an irritant, it activates this inflammation immune system, which releases inflammatory mediators. Plus, that plus is the COPD. What is that? Plus proteolytic enzyme. Proteolytic enzyme. So we have mucus production and cough, mucus hypersecretion, excessive mucus production. Again, the combination of inflammation and mucus builds and contributes to your airflow limitation. So what's really happening is we have inflammation, and we also, that inflammation leads to mucus production. This plus this leads to airflow limitation. You're not able to breathe properly and can lead to periodic worsening of symptoms over a period of time and even exacerbations. That's how a normal lumen looks like, and that's what a bronchitis lumen looks like. So there is so much of buildup of your phlegm, mucus, and inflammation that there is less place for the air to move in and out. And this is your tertiary bronchi, the lowest close to your alveoli. All good? How are you feeling? Moving forward. Shoot. Okay. I just highlighted I thought like this highlight is basically the answer, but I'm not. I'm gonna take time to read through it. I'll take a break. Go ahead. The first answer. A patient with chronic bronchitis experiences persistent productive cough. What is the underlying pathophysiological change that explains the symptoms? So we have alveolar destruction with reduced lung compliance, bronchial muscle spasm, goblet cell hyperplasia and increased mucus production, pulmonary fibrosis. Okay, I highlighted something over there to leave it as a cue. We're talking about bronchitis. I do understand COPD, talk about alveoli and all of it. We haven't got to that because that is your emphysema component. At this time, what we're doing is only chronic bronchitis. So with that in mind, and transitioning from the previous slide, which is the best response? Alveolar destruction. Okay, alveolar destruction doesn't cause bronchitis. Alveolar destruction causes emphysema. Okay, alveolar destruction is basically your emphysema component of it. Then the same is pulmonary fibrosis. That is again your emphysema component. So we are left with A and D is eliminated. Bronchial muscle spasm, narrowing the airway lumen. Thus, spasm leads to itis. Spasm is contraction. Itis is inflammation. So which is speaking to inflammation? Goblet cell hyperplasia and increased mucus production. Will that be the answer? Do you work like this in your exam to eliminate the choices and get the right response? All right. A 65-year-old man with a 30 pack years smoking history reports worsening breathlessness and chronic cough. Based on our understanding of airway inflammation in COPD, what is the most likely cellular mechanisms triggered by the smoking? What is smoking really doing? Does it do anything with your eosinophilic mediated allergic inflammation? I'm going to eliminate that. As soon as I see those eosinophils, that's all asthma. Activation of mast cells, histamine, that's all. Okay. Recruitment of neutrophils and macrophages. Suppression of T lymphocytes. Why will it be suppressed? Because T lymphocytes will be activated. So that's again eliminated. So who's left? Recruitment of neutrophils and macrophages causing tissue injury. Moving forward, a researcher is studying lung biopsies from COPD patients and observes elevated level of neutrophil elastase. What is this enzyme? We discussed in the last slide. NE is neutrophil elastase, responsible for breaking down elastin. Elastin is the protein responsible for elasticity of your lungs. Okay, so we have this enzyme, which, they found out that there are elevated levels of neutrophil elastase. And as soon as you see that name, you're basically thinking of COPD, because we're not talking about elastase in any other disease except for COPD. And then matrix metalloproteineases. This is coming directly from a textbook, the Golan textbook. They also talk about this. We don't know a lot about that, so we don't talk about it. So we just keep our whole topic on elastase only. Which clinical consequence of immune activation do these findings help explain? Bronchospasm, reversible. As soon as you see reversible, COPD is an irreversible disease, you eliminate that. Enhanced mucociliary clearance. Mucociliary clearance is not enhanced, it is reduced. Tissue destruction and airway remodeling, and alveolar regeneration and tissue repair. B, alveolar regeneration and tissue repair. Alveolar regeneration or degeneration. You see that? What is the difference between D and re? I would select alveolar regeneration if I'm not paying attention to that D versus re. What is D? Destruction. Re is replacement. Is your alveolar getting replaced with something much better? Yes, it does replace because that's your human compensatory mechanism, but it replaces with something, a tissue which is less of an elastic recoil. Okay, and does it have tissue repair? So what's the answer?
Tissue destruction.
Okay, moving forward. Which of the two features are most common characteristics of chronic bronchitis? Chronic bronchitis again. We're not talking about emphysema here. Mucus hypersecretion and airway inflammation. Mucus plus inflammation, mucus plus inflammation, mucus plus inflammation. That's a chronic bronchitis. Okay. In the last slide, if you cannot, then put somewhere like equation, just go ahead and put it. Because this whole slide is based only on those two important features of chronic bronchitis. Moving forward, what are we moving to? Emphysema. We discussed so far about COPD, which is a heterogeneous lung condition. Characteristic features are chronic bronchitis and emphysema. Chronic bronchitis is characterized by chronic cough and phlegm. Plus, this chronic cough and phlegm is associated with goblet cell hyperplasia, which is increased mucus production and inflammation. We're moving to your emphysema, which is basically at the level of your alveoli. The parenchyma, basically the tissues, structure of your alveoli are getting destroyed. Let's see what's happening here. So in emphysema, the tiny air sacs, basically your alveoli are gradually getting destroyed. If you don't know the function of your alveoli, it's going to be very difficult. So what is alveoli responsible for? Everyone. Gas exchange. So you are basically destroying alveoli, leading to reduced gas exchange. What's the final outcome? Where are we getting at? Hypercapnia, hypoxemia. Hypercapnia, hypoxemia. Reduced gas exchange. The surface area for gas exchange decreases, right? Alveoli has tissue, so the surface area gets reduced. It impairs the absorption and carbon dioxide, impaired oxygen absorption, yes, and carbon dioxide expulsion results in a condition of hypoxemia and hypercapnia. For folks who doesn't know that, hypoxemia is decreased oxygen levels in the blood. Hypercapnia is increased carbon dioxide levels, okay, in the body. Hyperinflation. Damaged alveoli cause lungs to become overinflated, trapping air and reducing elasticity. You got to understand this. So there are a couple of things we have so far discussed about bronchitis because it was a replicate of your asthma. In emphysema, in addition to hypoxemia and hypercapnia, some of the features you have to remember is collapsible air tubes, overinflation, air trapping. Like you have to know this, and then we will demystify this in a bit. Air trapping, can you hold that? Collapsible airway walls, remember that, okay? That's all your emphysema's hallmark features. What really happens is damaged alveoli. You can see this diagram over here. So let's talk about this diagram. This is a diagram for fibrosis, okay? And emphysema is different from fibrosis, and there are reasons which we can, in the later slides, we'll talk about that, but I could not get a better diagram to explain this. So that's your bronchi, basically your tertiary bronchioles, and this is basically your alveoli over here, and these red color ones are your blood capillaries. So there is so much of distance between your blood capillaries and your alveoli. So your alveoli takes the oxygen, it slowly transports it to your blood. The blood takes the oxygen out to all the tissues, and it brings back carbon dioxide. It takes, and then when you exhale it, the carbon dioxide goes up. Okay, that's happening in the mango people, like you and me. Okay, we move to the fibrosis or emphysema condition. The air comes in because it has good passage. What happens here? There is going to be decreased gas exchange. So what happens to this alveoli? Alveoli are destroyed. So remove the alveoli for a minute. No more alveoli. But there are tertiary primary bronchioles, secondary bronchioles, and tertiary bronchioles. So the air will keep coming in, but they will not have alveoli for gas exchange, decreased gas exchange. Hypoxemia and hypercapnia. That's all it leads to. And also remember that there is airway trapping, collapsible ATOs. I will explain you that what's happening here. So elastic recoil is reduced, right? So what happens now? So the air comes in, it opens, the air has to push out, so it has to contract. So this contractility, because there is elastic recoil capacity got reduced, they cannot contract. So the air doesn't go out. So the air stays back in. Oxygen has to come in, carbon dioxide has to go up. Imagine a situation where 50%, like 100% oxygen, 100% carbon dioxide. Now the air is not moving out completely. So if the air is not moving out completely, what is the air here? Carbon dioxide. Oxygen converts to carbon dioxide in your body. Carbon dioxide is here. So not everything is going up. So how much carbon dioxide is here? Imagine there is 20% carbon dioxide. So you will only allow 80% to come in because carbon dioxide is taking the place. So 80% oxygen coming in. So that 80% slowly, again, not proper contraction. So that leads to 40% carbon dioxide staying back, only 60% coming in. 60% carbon dioxide stays back, 40% coming in. 80% carbon dioxide stays back, 20% coming in. Over a period of time, only carbon dioxide stays back, no oxygen coming in. Because there is only so much space inside. Okay? If your body is not contracting or expelling it out, it's not allowing new air to come in. Because if it's already saturated, you cannot allow more air to come in. So ultimately, that's how that hypercapnia and hypoxemia condition leads to. Are we clear? The loss of elastic recoil is one of the problems, and that's one of the reasons what it looks like is their lungs on a biopsy looks hyperinflated. Oh, there is no problem, like oxygen, but the problem is oxygen, once it comes in, it has to be contracted so the carbon dioxide goes. So the problem is your lungs have lost the elastic recoil because the alveoli and the elastin component of that alveoli is lost. So they no longer contract. If you understand this, you're done. All right. That's your hyperinflation and things like that. Are we good? Can we proceed, Michael? All that I explained in the previous slide is in so many words here. This is a different way of looking at your actual bronchi versus a bronchi which is emphysematous. All right, so it has very, very wide pores. Or, so much of oxygen is coming in. Yes, so much of oxygen is coming in, but that oxygen to basically get replaced by carbon dioxide, that's not happening. This oxygen converts into carbon dioxide, but the carbon dioxide is not getting eliminated because my elasticity is all gone. I'm not evacuating my carbon dioxide. So less oxygen comes in, and less oxygen comes in over a period of time. Your tissues are getting deprived of oxygen, finally leads to, I don't know about the death, but that's what it ultimately will happen. If your tissues are getting starved with oxygen, that will be a problem. So there is a term called as compliance. Anyone remember the definition? Compliance. Well, compliance is equal to volume by pressure. C is equal to V by P. This is coming from your biomed pharmacology. Compliance is equal to C is equal to V by P, where we have volume divided by pressure. Okay? Always remember, in compliance, write down this very clear. In emphysema, there is increased compliance. Write this down. In pulmonary fibrosis, there is decreased compliance. That is the distinction between your emphysema and pulmonary fibrosis. Because you will get confused. Sometimes you will see reduced compliance, somewhere is like compliance. Yeah, your cells, your body is not compliant. It doesn't mean that. There's more of a scientific understanding behind what does compliance really mean. So far what we did is discuss. We discussed about compliance and we're trying to understand the definition. The definition is coming from compliance is equal to volume by pressure. In emphysema, there is increased compliance or decreased compliance? Gotta remember this. Keep telling. Emphysema, increased compliance. Emphysema, increased compliance. Pulmonary fibrosis is decreased compliance. We'll not even talk about it. Just it's there for you as a note. We are only focusing our lecture on emphysema. Increased compliance means more volume because directly proportional, less pressure. Okay, your body doesn't need a lot of pressure, so volume comes in. So that's what it says. Emphysema, the destruction of elastic fiber increases compliance, meaning lungs can expand more easily, but collapse more difficulty during expiration. They are open like this, but just like that, they cannot collapse, and that makes expiration very, very difficult. Okay, so there is more air which is coming in, but more air is not going up. That air is staying back. That air gets converted to carbon dioxide. So only if less air is going out, only that much air is getting replaced. Because you have to understand that in a balloon, there can be only so much of water. You add more water, there is no place, it will fall down. So over a period of time, less oxygen coming in leads to a condition called as hypoxemia and hypercapnia. High compliance combined with destruction of alveoli cause air to rush in easily but become trapped during exhalation, leading to hyperinflation or air trap. Inefficient gas exchange, they have higher volume but decreased functional capacity as destroyed tissue cannot effectively participate in gas exchange. Over a period of time, progressive air trapping leads to less air moving out, which results in less air coming in. Less air moving out means less air coming in. This causes airways to be narrow and more collapsible during expiration. If you cannot understand any of this, just remember that emphysema is increased compliance. There is more probability for the air to come in, less probability for the air to go out. When we talk about air, we talk about oxygen coming in and carbon dioxide moving out. But if carbon dioxide is not moving out, oxygen cannot get replaced. Okay, that is a problem here. Let's go through a knowledge check. Are we all feeling comfortable? We can do the knowledge check. Let's do it. What structural change in emphysema primarily leads to reduced gas exchange? What structural change? Structural change. Destruction of alveolar walls. Okay. Which of the following best explains increased lung compliance observed in emphysema? Destruction of elastic fibers. Okay, now you understand the concept that there's less elasticity means less ability of the lungs to expand and relieve the carbon dioxide out. That becomes a problem. Moving forward, a 66-year-old man with severe emphysema complains difficulty exhaling. His lungs are hyperinflated. What does it mean? Hyperinflation, airflow limitation. I mean, airflow limitation is kind of very biased. Hyperinflation, collapsible air tubes. If you see those keywords, close your eyes and see where is COPD and select that answer. Because there is no other thing which is out there which mimics similar symptoms, at least with the respiration. Okay, so hyperinflation is one of the characteristic feature of emphysema. Which of the following best explains this finding? Collapsed airways and trapping air during expiration. All right, there's nothing to do with your mucus. Mucus is all your chronic bronchitis. Reversible bronchospasm, there is no reversible for COPD. Okay, sorry. A patient with advanced COPD shows signs of hypoxemia and hypercapnia. Based on the emphysema pathophysiology slide, what mechanism most directly contributes to this gas exchange impairment? Okay. Does anyone don't think B is the right answer? What can explain hypoxemia and hypercapnia?
Loss of surface area.
Surface area. So that should be your answer. How are you guys feeling? COPD, heterogeneous lung condition, characterized by two important symptoms: chronic bronchitis, chronic cough, and phlegm, which is basically characterized because of hyperimmune response or whatever you call it, inflammation, and goblet cell hyperplasia causes mucus production. That's all your chronic bronchitis. The second component is your emphysema. Emphysema is damage of your alveoli walls. Damage of the alveolar walls leads to less gas exchange. Less gas exchange leads to hypoxemia and hypercapnia. And what is the science behind it? The science is that the compliance is getting increased, so the air can easily flow in, but since the whole tertiary bronchi is completely eroded, you see, like when there is a cyclone in the forest, the cyclone takes everything away with it. That's what's happened to your tertiary bronchi. All that irritants or cigarette smoke and everything, it's kind of clearing the forest. We need the forest. We need those alveolar beds. If you're clearing it, it's losing its alveolar capacity, which is gas exchange. It's losing the elasticity because the elastin is getting eroded as well. And that way, it leads to less expiration. More carbon dioxide is staying back. That is becoming a problem over a period of time. All good. I just summarized in the like 1 minute everything what we discussed so far. Alright, so this is a slide which we also saw in your biomed. It's talking about in the context of like spirometry, vital capacity, and residual volume, what really happens. Residual volume is the volume of air which is left after a complete exhalation. So if you can see this first slide in a normal patient, he has higher vital capacity, less residual volume. But what happens is over a period of time in a COPD patient, his vital capacity gets reduced because there is more residual. What is residual? Anything which is a residue left. So what is the residue here? Carbon dioxide, which is not getting out because my lungs are not expanding or contracting properly. So it's not contracting, it's not flushing everything out. Flushing everything out is imperative so that everything new comes in. You keep keeping stuff inside, there is less room for new oxygen to come in. New oxygen means less more of carbon dioxide and hypoxemia and hypercapnia. So it's also speaking the same thing. Moving forward, the knowledge check on your residual volume. Which of the following best explains why residual volume increases in patients with COPD? B, A, bronchial vasoconstriction. Will that really relevant to this condition? We're talking about residual volume increase. What causes residual volume to increase? Elasticity. And what is the choice which is talking about elastic recoil or whatever? All right, so reduce elastic recoil and air trapping. A 70-year-old man with severe COPD reports presence with dyspnea and confusion. Arterial blood gases reveal hypoxemia and hypercapnia. What mechanism best account for this finding? All right. There is only so many ways I can ask the same question. Okay. You understood the concept. You're gonna get to it. And the same thing, like. So now you're trying to understand, like, if you hold those couple of keywords in your head, are you reading? To be honest, I'm not reading the whole multiple choice question and my answers. I'm trying to identify where is air trapping, collapsible, hypoxemia, hypercapnia, elastic recoil, neutrophil elastase, like all these terminologies. So it comes with practice. So you're only identifying that, and anything which is irrelevant, it gets eliminated right and left. Okay. I would encourage for you to read through it, but sometimes, in the interest of time, you've got to get through the science so that you can spend more time on your clinical questions. Okay. How are we doing with the time? Slide 16. 5 more minutes and we'll take a break. Is that okay? Go through this slide. We talked about proteases, right? Proteolytic enzymes. So you're talking about how important it is the balance between your proteases and antiproteases. Remember the first or the second slide we talked about alpha antitrypsin? That's all comes relevant here on this slide. You see a balance here? So there's always a balance between your proteases and antiproteases. Proteases are, ACEs are enzymes which are going to cause destruction. Proteases are enzymes which destroy proteins. Antiproteases are enzymes which prevent the destruction. Okay? So why do we need those? We need for our body, this is all our inherent compensatory response of any human body, that anything which is damaged inside, you won't go inside and start tearing your tissue apart and replace it. Your body repairs by itself. But the problem is in the context of repairing, it repairs with a tissue which is not what the actual tissue was. And the actual tissue had elasticity, the actual tissue had a lot of other things. That the new tissue is more rugged because what is Charles Darwin theory tells? Survival of the fittest. The fittest can survive. Your body knows that theory. And it only keeps replaced with the tissue which can survive the smoking, the biomass fuel, the organic acids out there, the exposure. It can only survive that. But the problem is that survival is not letting us survive for a long time because those tissues are not doing what it has to do. There is functional capacity loss. The functional activity of that tissue is going to get compromised. So proteases, antiproteases, always a balance is regulated. What happens in a COPD condition? There is an enzyme which is getting released. What enzyme is that? Neutrophil elastase, which is a protease or an antiprotease. It's a protease. Elastase destroy elastin. Elastin is the thing which gives elasticity to your lungs. So it destroys elasticity, sorry, the elastin component. So proteases increase, antiproteases automatically gets reduced. So that will lead to a problem of destruction of your tissues and parenchyma and alveolar, decreased gas exchange and all of that. So inhibits neutrophil. So what usually happens with the antiproteases? It has the ability to inhibit this. So if you have a good levels of antitrypsin or antiproteases, we call it, they have an ability to reduce this. It's possible, right? If I drink a cigarette smoke, it's going inside, but then what happens? Your body has a defense mechanism where antiproteases, oh, you know what? The proteases is slowly going to go and damage. Let's increase the antiproteases. They go and they stop the inhibition. So that way my tissue, like with one exposure, will a person end up getting a COPD? No. There are antiproteases which are the defense mechanism will inhibit the activity of your proteases. Okay? It provides 90% protection. Genetic variants. One of the things which you have to remember are risk factors, people who have antitrypsin deficiency. What does it mean? The first is completely not there. No more antitrypsin, no more production. No more production leads to no more elastase inhibition. No elastase inhibition leads to elastase levels increasing, destruction of alveolar beds, and the whole cycle repeats. Are we good? Okay. Yes.
So I didn't understand what's the natural function of proteases. Is it?
Proteases are the enzyme responsible for destruction of proteins. Proteases basically cause destruction of proteins. They are there, but they are there for in a mechanism where your body needs to clear debris, or there are cells which are dead. It clears it up. That's what it has to do. Yeah, clear debris or clear anything which is not good. Why will our body create destruct proteins? So usually when we do experiments in the lab, we get DNA and the cells. The first thing we add it is the protease, so that we destruct the cells and then we analyze the DNA separately. Because in a cell they have millions of DNA. Can we break it? Punch it really hard? The cell doesn't break with a punch. It has to go at the level of the cellular level to destroy the linkages between the proteins, and that way every cell will be separated. Okay?
And then trypsin is a type of protease, right?
Trypsin is a type, I don't know that. Antitrypsin, trypsin. Probably we can call it. I'm not going through this. You understand the meaning of it, right? And we have neutrophil elastase. Who doesn't know neutrophil elastase by now? Can anyone tell me what is the function of elastase? Don't it down. Elastase are? Elastase, break down elastin. As simple as that. Okay? And then we have all those vocabulary for you to read at your own pace. Moving forward, which of the following best describe the primary role of antitrypsin in lung tissue? See, a 34-year-old non-smoker develops early onset emphysema. Genetic testing reveals he has deficiency of alpha antitrypsin. Which of the following best explains how this deficiency contributes to his condition? D as in Delta or B as in boy? Okay. Why are we talking about B? What is that keyword there? Elastase, antitrypsin. Okay, there is something going on there. What about mucus and all of those things? They're all, so now you're in the class, you're learning this concept, you have to be so confident when you go to the exam because it's the same thing I'm asking you in the exam. So what really happens is when you keep adding stuff to your brain with other components, you may end up, but it's all practice. You can get there. The answer should be B, excess elastic activity. I'm gonna stop here, go take your break, come back like in 5 minutes. I'll start exactly at 10:06. Thank you.
How are you?
Welcome to our class.
Y'all can't see them?
I thought y'all could.
I see it.
I thought y'all could. I went in there and I was like, oh, I in Thursday, I was like, oh, they were. And then that makes sense. So I was like, they're quiet, close to the face.
Yeah, you can see it. We had a whole break.
We finished with this.
I bet y'all can see Hey, they will pay attention to class.
Michael, do that again. Do it again. Since we exposing each other. I got you.
Yeah. So the family friends.
Yeah.
I would just
They gave you how
No. You don't Baltimore. You need to work in like Alabama. You gotta work somewhere with everybody.
Yeah.
We know how to hardcore. Nobody went to work.
You'll see a string of emails. I'm trying to arrange a test with the test taking center so that I can keep the original exam date. Because this is not my class. That is the second is my last date. I'm not moving it back. I won't come. You guys can feel me. I'm not coming on the 5th. I need to take the test on the 2nd. And I don't want to impact them because that is an issue for them. So I just would like to honor the original date.
You sent an email, right?
Yeah, but the testing center is saying no.
Why?
Because I don't have actual test accommodations. Like I don't need extra time. I don't need extra anything.
So then why did you send to testing accommodation the email?
Because I was originally told that if I don't take the test when the class takes the test, then I'm supposed to contact the testing center. I just spoke to Dr. Bailey, and she's like, that's not accurate. So I would like to take the test on 5/2 at the 11:30 at the normal time. Is that something you and Dr. Grisby would be able to honor via using Miss Mina as a proctor, or how do you guys handle it?
When is 5/12? It's a Friday.
Yes,
and you
next
can do
Friday.
that 10 to 12.
The normal schedule time is 11:30. That's fine. If you want to move it up to 10, that's fine too.
Yeah, I mean, I'll be mostly be on that floor. Dr. Vijay will be at the bottom. He probably would be at the clinic or something.
Okay.
For me to be in on Fridays, I usually had to leave like around 1 o'clock, 1:30. So
10 to
if
12.
yeah,
10 is fine. I can do 10. Friday 10. I'll be there.
if that is okay, then probably we just have to like talk to Dr. Grisby, and I don't think there is going to be any pushback. So just prepare yourself. Make sure that you write the exam and you forget what you have written. Not with the question. I mean, say like keep the concept with you. And don't talk to anyone in the class. I mean, you understand
Yeah, I
these
know.
things. I don't even have to tell you, but that's kind of what.
Yeah, that's been I've been mum the whole semester. They don't know I take the test at different times and stuff.
Perfect. Yeah, we can. You want us to reply back? Hopefully, that's one thing. The fifth one is one more thing we have to take care of. What else? Did the kids got released? Did the kids got released?
I didn't see it, but I haven't been on my computer.
What is it saying? Okay. So go and just refresh your thing and see if you get the release. I think these were the three things which were pending. Okay.
I like those chips. Passover's over. Yeah, you're correct. I had to fight real hard. Easter was not dress time for me.
All right. Welcome back. We're halfway down. I promise I want to finish this before we leave. I guess once we get through this, there are like 5 slides which talks about structural changes, and then we dive directly into a pharmacology. All right, please settle down. All right. We talked about asthma, COPD. How is asthma and COPD different from each other? This is the slide which speaks to it. Okay. The T lymphocytes in asthma pathophysiology. Which one is it? TH1 or TH2? 2, 1, 2, 1. 2. Everyone on board? Okay. So it's TH2 biased, especially with your asthma disease. And that's kind of like what this slide is basically a recap of talking about asthma. So we can just go through that quickly. I'm going to start from here. T helper cell activation. Allergen exposure causes activation of TH2 cells in asthmatic airways. This asthmatic airways then activates T cells to cause release of 4, 5, and 13. What is 4? What is 5? What is 13? 5 is eosinophil. I know that. But what is 4 and 13?
4 is IgE.
And what is 13? Perfect. Okay. So they do all those functional changes when an allergen gets activates a TH2 cell. This causes recruitment of more eosinophils, like this primary and the secondary mechanisms of calling all those inflammatory mediators to cause release of inflammation. Now it's becoming more of an hyperinflammatory response. And one of the things I always want you to remember with your bronchi is not everyone who gets exposed to an allergen ends up becoming an asthmatic. There is something different in that person who is having asthma. One is his TH2 expression. The other one is because of that expression, he ends up having hyperreactivity and hypersensitivity. He reacts to something which he doesn't have to react. He's sensitive. Any small little allergen can elicit this hyperinflammatory response. And then this airway hyperresponsiveness, as I said to you, causes bronchoconstriction and mucus hypersecretion. So as we spoke about asthma so many times, this is all coming very easily, at least for me. How do you guys feel? Just raise your hand if you don't feel it's coming naturally to you. Means then there is a gap. And don't take me wrong, you can still cover the gap. Okay? Either trust yourself and read the handout or stop at the instructor's office. Because I don't want to see you in ECR. No one. ECR means you're sitting back in summer in the school. All right. If you understand this, the next 6 slides is basically talking to this slide. We're talking about those structural changes so far. What's really happening with respect to the just like your Th2 phenotype, you remember there was Th2 and then it goes on to activate IL-4, 5, 13, and then all that in asthma. This is the slide for COPD where when a person gets exposed to an irritant, which is kind of like a cigarette smoke, in this case, what it happens? The first thing the cigarette smoke does is, this is not something which is endogenous to you. Your body likes cigarette smoke. And why do we do it? Pleasure, stress, okay? There are many other stress busters out there. Don't put something which is xenobiotic, because the first thing the body does is, this is not for me. It's going to activate macrophages, which are going to camouflage, or whatever you call it. What is that called? Apoptosis and stuff like that. What the macrophages really do? It camouflages those irritants. Okay, so activate macrophages. These macrophages, it's not a one-step process. These macrophages, you activated a small thing in your body, it's gonna create all the disturbances. Okay, so macrophages is the first thing you have to remember. So the easiest way to remember is, in case, I don't know how to measure this clinically, but if I had to basically differentiate between a COPD and an asthma patient and I could measure macrophage, that's what I would measure in this patient. If a person has a higher plasma level of macrophages, which I don't know whether there is a test to do that, but if it is, then that's what you get at. If a person has high IgE, that's your asthma. Eosinophilic, because that's mostly your asthma. The patient has a lot of macrophages, that's basically your COPD. So these macrophages cause release of the CXCL proteins. These are called chemokines and cytokines. Okay, what are the function? Chemokines, cytokines, inflammation. Okay, they're all those inflammatory mediators. So they cause release of this protein, this chemokine cytokines, which go and activate a neutrophil. These neutrophils are going to release what? Neutrophil elastase. This neutrophil elastase and matrix metalloproteinases will go and act on your bronchial cells to cause mucus hypersecretion, and on your alveoli to cause emphysema. That's your chronic bronchitis, that's your emphysema. All good. And then there is all those things which it takes support of doing it. So we take support of TC1 cells. Remember when we had those in the actual differentiation pattern, we had cells responsible for asthma and cells responsible for COPD in your asthma slide. We discussed about the TC1 cell at that time. So that's where it gets activated. They all cause basically destruction of your alveoli. So what's your end outcome? You have to reach to this end outcome. And you take support of all those inflammatory mediators, and basically they are chemokines, cytokines, monocyte, neutrophils, macrophages, TC1 cells. Can you remember this? Neutrophils, macrophages, chemokines, cytokines. Neutrophils, macrophages, chemokines, cytokines, TC1 cells. They all come together and basically try to help you. Okay, so they're kind of like getting activated. You activated them, right? You smoke a cigarette or you got exposed to something. It's not something which is genetic. We're not talking about people who have genetic. These are lifestyle exposure. This is something about a person's lifestyle. So he activated his whole hyperimmune kit in his body. It leads to all the destructions of the bronchial cells, goblet cell hyperplasia, subepithelial fibrosis, mucus hypersecretion, alveolar damage, air trapping, airflow limitation, hypoxemia, hypercapnia. Okay, all of that is what we expect. There's one thing, addition to that, they also go on to damage your epithelial cells. Remember, we discussed about epithelial cells, which are very, very elastic and all of that. So those basically converts into fibroblast, and this fibroblast gets attached over here. So these fibroblasts are the additional thickening of the basement membrane, because epithelial cells are good, but my body have understood that it's not able to resist the cigarette smoke or those irritants in the cigarette smoke. So it's basically creating an additional layer. It's helping me. To be honest, if you look at it from that perspective, your body is creating this fibroblast to help you, so that the next time a person gets exposed to that irritant from a cigarette smoke, it is not causing damage, because they don't get damaged. Less work, yes or no? But the problem is, because of this additional fibroblast, what is happening? The cells are losing its elasticity. They don't recoil well. No recoiling well leads to No expelling carbon dioxide out, carbon dioxide stays back in, hypoxemia, hypercapnia. All good. I have all this information for you guys for you to read. That's all it's talking in the slide. Thing as such interesting, which I may missed. One of the things which you can see is GCSF, granulocyte colony stimulating factor. Sometimes, with all these things happening, they need some support system. GCS is the support. You can just put in a bracket. I'm not going to test you on that. It's not very clinically relevant, but they also help with neutrophil production and differentiation. One of the things which we didn't talk about with respect to your monocytes, we'll talk about there, but you can see the monocyte, there's a direction which goes back. You see that arrow? Everything is like going in one direction, but then the monocyte, the direction is opposite. What is monocyte really doing here? What does that mean? Monocytes are going to activate more macrophages. So it's basically the way you call it, it's called replenishing macrophages. What are macrophages? They are there for camouflaging the dead cells. They activate, they do all this inflammatory process. It's a problem. If it would have been at macrophage level, to be honest, there's no problem whatsoever. The problem is this macrophage causes all the secondary differentiation into or release of neutrophil elastase. That's becoming a problem. As such, macrophages release is not bad because we need that. Your body gets exposed to it. For an infection, look at an infection. You need macrophages to kind of come out of that, but all this is going to cause problems. Proteases is one thing which you always have to remember. Coming to proteases, we talk about the roles of neutrophil. What does neutrophil do? They're recruited by macrophages chemotactic factors like CX and CL proteins. GCSF as a support system extends the neutrophil lifespan. Neutrophil secrete neutrophil elastase. And what is this again? Elastin protein. So this elastase basically causes destruction of the elastic proteins in the tissue of the alveoli, results in reduced compliance. And again, remember, I always told you emphysema was pulmonary, increased compliance. In pulmonary fibrosis, we have means reduced volume. So the amount of air which actually comes in a fibrotic tissue is also less. The problem was in emphysema, the volume was higher, it was getting in because there was direct proportional. Here, reduced compliance means reduced volume as well. So even less volume is entering into your lungs. Forget about the carbon dioxide because the lungs doesn't really expel out that much. And inflammation and increased mucus secretion. How are we feeling? Okay, are we repeating the same thing again and again? By now, did I convince you that neutrophil elastase is that protein which is distinct compared to an asthma, where we don't talk about this protein. We talk about all the inflammatory mediators plus this protein, which goes and damages your alveolar buds. Alveolar buds has elastic recoil capacity that gets influenced, that leads to less expiration, more carbon dioxide staying back, more hypoxemia and hypercapnia. Monocyte, as I told you, macrophage replenishment, that's one of the most important functions. Remember, monocytes, macrophage replenishment, you cannot go wrong there. Okay, that's the important function of monocytes over here. As much as macrophages gets completely depleted, so it gets replenished by these monocytes. It stimulates the function and inflammatory mediators. As such, the whole process is all about inflammation. Epithelial cell damage. We discussed about this. One of the things your textbook is talking about is how the change in the epithelia is really happening. So normally, in the next slide, we're going to talk about that, but it's like columnar epithelial cells get replaced by squamous, which are flattened shape cells. Okay, in the next slide, we can see that. But again, this is all fibroblast production, which causes scarring, triggering of tissues, and for the most part, you understand this slide because we discussed this in the previous slide. So this is something new, the squamous metaplasia. This is how it looks like on a slide of a tissue. The change in the epithelial morphology with squamous appearance, flattened and protective function to further damage epithelia. So impaired defense. So you can see this is your column, and this is your squamous. You can see the cells have changed the structure. They are more columnar, but here they are more like square, and they are squamous, like flattened. What does this black color here mean? These are the cilia. So they are ciliated epithelial cells. What was the function of a ciliated epithelial cells? To remove the debris. So no longer your cells have a potential to remove anything. The protective function is compromised. Okay, reduce mucociliary clearance and defense against pathogens, and finally, the irritant exposure is basically causing all of this to happen. Okay, so exposure to irritants like cigarette smoke leads from this cells to that cells. That's your take home. Can you remember that? Epithelial columnated epithelial cells converted into squamous cells. What is metaplasia? Oncology. How does cigarette smoke cause cancer, right? Remember cigarette, does it have like those lung like cigarettes box? It causes cancer, something like that? It's warning message, right? What it really means is like initially your body will try its level best to kind of convert squamous to metaplasia, and then this metaplasia converts into dysplasia leads to carcinoma. So there's like a good thing, which is, I'm not going to test you on this, but for you to understand what this really means, it doesn't stop here. I mean, you feel like, oh, you know what, everything is at peace, I don't care, my cells get elastic recoil, I can still live with 50%, I have made peace. 50% carbon dioxide, I'm okay with it. But that doesn't stop there. That's the problem. You keep hitting your cells where these cells will move on to become more in number, and then it will lose its functional capacity, finally leading to carcinoma. Okay, that's the final thing. And then you say tata bye-bye to your work. Okay. Let's do a knowledge check. Which of the following best describe the role of alveolar macrophages in pathophysiology of COPD? We're talking about macrophages here. Go back and think about what the diagram was. Macrophages, what was the next? They release inflammatory mediators and stimulate immune cells. What structural changes is most associated with epithelial cell injury? Yep. Squamous metaplasia and loss of ciliary function. A COPD patient shows persistent inflammation and mucous hypersecretion. Which sequence of immune events best explain this progression? C. Monocyte recruitment, macrophage activation, neutrophil recruitment, and protease release. Are we all on the same page? Finally, a patient with COPD presents with increased susceptibility to infection. Biopsy reveals squamous metaplasia in the bronchi. What is the most likely functional consequence of this epithelial change? Impaired mucociliary clearance and reduced pathogen defense. All good? All right. That's all. How much time do we have? We just need 10 minutes from here. Do you want to do a rapid fire?
Yes.
All on board? You want me to summarize what we have learned so far? Or you're good? I've summarized so many times that now Professor please leave us. Are you feeling comfortable? That's going to be a major chunk of the questions in the exam. Okay? So if I can put, probably just thinking out loud here, out of 20 questions, expect 15 questions only from your pathophysiology, because that's basically your first 3 learning objectives. The final objective is just probably 5 questions. Okay? All right, let's do a rapid fire. So we're talking about drugs which can be used for COPD. We had a bronchoconstriction, which is to some extent not what we want it to be, because remember, always think about COPD, how it is different. COPD is 2 conditions, bronchitis, emphysema. Bronchitis, emphysema. In bronchitis, what really happens is mucus, the airway gets clogged. So the only way bronchodilators can help is just dilate to some extent. It's going to be like a symptomatic help. It's not really trying to help them. So we talked about drugs with respect to your SCR. We talked about albuterol, which has the terminal amine. And this terminal amine causes more beta-2 selectivity and lower affinity. So one of the things I can remember right now, which I'll talk in a bit, is the olive-albuterol rotation of hydroxyl group. In the exam, there was a question which asked you about which particular substitution or something can cause more beta-2 selectivity. And it clearly mentioned increased beta-2 selectivity. And I found most of them talked about hydroxyl group. What is the hydroxyl group really doing? You got probably to carry a bit so far about levoalbuterol. It's just there. Levoalbuterol versus albuterol, the rotation of hydroxyl group is only going to cause less of a cardiovascular side effects. But more importantly, we are still sticking with albuterol as one of the important prototypes to be used for asthma and also now for COPD, because beta-2 selectivity confers its selectivity to beta-2 as well as the terminal amine substitution over here. This substitution basically confers that selectivity to terminal to beta-2, and it also lowers the affinity to FOMO. Okay, it's the same thing in different words. All right. We discussed this slide. I found this slide probably on internet. That's the source to it. Talking about beta-2 agonists as bronchodilators, what is the mechanism? We saw this mechanism already. I'm going to come down to this mechanism where we have a beta-2 agonist. What happens? Beta-2 agonist binds to your beta-2 receptor. Beta-2 receptor causes... No, not directly. You're going so fast. Kingsley, we've got to take a step back. Beta-2 leads to binding to beta-2 receptors. What's next? All those alpha proteins, the GS gets activated, converts ATP to cyclic AMP. Cyclic AMP leads to conversion to AMP. If it converts to AMP, then it stops there. We don't want it to convert to AMP, and that's one of the reasons we have other drugs which can help there. We have a drug called as theophylline. What does theophylline does? It inhibits this enzyme. What is PDE? Phosphodiesterase. So you inhibit this enzyme here, what happens? More cyclic AMP or more AMP? More cyclic AMP. More cyclic AMP then activates protein kinases. Protein kinases then cause decrease in the MLCK. What is MLCK? Myosin light chain kinase. They are responsible for contraction. You inhibit the contraction, leads to dilation. It also inhibits this pathway, phosphoinositol calcium pathway. That's one of the other things which you can think about. One of the other things which protein kinase also does is it phosphorylates this channel which has potassium in it. So what happens? Potassium goes out of your cell. Potassium has this charge, positive charge, right? If the potassium is exflux out of the cell, what happens to the positive ambience of this environment? It is reduced. So we need a positive environment or a negative environment in a constriction episode. We need more of a positive or a negative. We need more positive. Why? Positive leads to depolarization, contraction. We need contraction, we need relaxation. Do we need contraction or do we need relaxation? So we need positive or negative again. Positive again. When you say positive, you talk about depolarization and contraction. I'm going back again. Positive leads to depolarization and contraction. Yes or no? Positive potential. So if you have positive in the cell, it leads to contraction. And person has already bronchoconstriction. Will it help him or will it make it worse for him? So how can you help him then? You reduce the positive to negative. That's what this particular drug is also doing. It's effluxing potassium out. So the potassium goes out, along with potassium, also the positive charge of it. Potassium goes out of the cell potential becomes, it will help reduce the depolarization or contraction and lead to relaxation. Okay, things to remember here. You already know the mechanism of MLCK, right? You already knew this mechanism. The other mechanism which you just have to remember is increased potassium efflux. Can you remember that? And I took some time to explain you because potassium has positive charge. You keep the potassium inside the cell is more positive. We don't want the cell to be positive because positive leads to contraction. We want to help a contracted episode, we're going to relax it. So how to relax it? We're going to efflux the potassium outside. Cool. saw this slide before, alpha 1, beta 1, beta 2. Alpha 1 is in your smooth muscles, causes vasoconstriction. Beta 1 is in your heart, causes inotropic and chronotropic effect. Beta 2 is in my lungs, causes bronchodilation. Beta 2 is also in my blood vessels, causes vasodilation. Beta 2 is also in my skeletal muscles, causes. Beta 2 is also present in around my, stimulates my glycogenolysis, causes. Okay. Glycogenolysis leads to, what is glycogenolysis? Breakdown of glycogen. Lysis is breakdown of glycogen. What is glycogen? Stored form of glucose. You break down glycogen leads to free form of glucose. Glucose is now higher in your system in circulation. It can lead to higher blood glucose. These are all the side effects. All cool? Good? Can we move forward? Yeah. Hypertrophy, anticholinergics. Okay. This is all explaining the slide over here, but we knew the mechanism. Hypertrophy is going to block the M3 receptor and the M1 receptors. What is M3 and what is M1? M1 is mucus, M3 is, you stimulate an M3 receptor, what will gonna happen? Stimulate an M3 receptor. This was the question in the exam, and most of the students who I met with, they all got wrong. You stimulate an M3 receptor, what are we expecting? Stimulate an M3 receptor, what are we expecting? Who stimulates an M3 receptor? You or me? Or we have a neurotransmitter which stimulates it? Who does it? Acetylcholine does it. If your acetylcholine is released in your body and it goes and stimulates an M3 receptor, what are we expecting? If acetylcholine goes and stimulates an M1 receptor, what are we expecting? Increase in mucus secretions, right? We have contraction, and how can we help the patient now? We help the patient by blocking acetylcholine to bind to the receptor. That's the reason they are called as anticholinergics. Anti means blocking cholinergic effect. You block the effect of acetylcholine on this receptor, what are we expecting? All the calcium associated release will be compromised or reduced. No calcium leads to no contraction. No contraction leads to relaxation of normalizing the problem for this patient. Why did we got it wrong? For those students who got it wrong, okay, it's very straightforward. I can see how that will work. You saw bronchodilators, you saw sympathomimetics and anticholinergic. You think they do the same? No. Sympathomimetics mimic norepinephrine, so they are agonist. Anticholinergics oppose. You know where you got wrong? The end outcome is, so your thought is bronchodilation or bronchoconstriction. I don't know what got wrong. If you're working towards bronchodilation, you have to work towards stimulating a system and opposing a system. Which system you will stimulate? Sympathetic or parasympathetic? Which system you will oppose? Are we all on the same page now? Okay. This is one of the SCR. Forget about everything. Just one thing which you have to remember is this quaternary ammonium compounds. Because of its hydrophilic nature, they are slowly diffused out from the tissue. This explains this long mechanism of action or long duration of action. That's one thing which you have to remember. This is a new topic we didn't discuss, but this is going to come back again to you. On this slide, you see a bronchial tone, which is basically a bronchial smooth muscle. The ability of bronchial smooth muscles is standing in between. It can contract, it can relax. So what thing which we have to do to this bronchial smooth muscles can cause it to dilate versus contraction. So we know that there is ATP to cyclic AMP to AMP. Yes, ATP is basically your effector adenyl cyclase causes conversion of ATP to cyclic AMP. So adenyl cyclase converts ATP to cyclic AMP then gets converted to AMP. Always remember, we want to keep it at cyclic AMP because AMP is the inactive form of AMP. What it means, it doesn't do anything. So how can we keep it at cyclic AMP? You can inhibit this enzyme which causes conversion into an inactive form. Example is theophylline. You inhibit the phosphodiesterase enzyme which we saw in the previous slide. There is more cyclic AMP level. which acts on your bronchial tone, what will happen then? Cyclic AMP causes protein kinases activation. Protein kinases causes two things: decrease MLCK and increase efflux of potassium. Okay. So you gotta tell the story. At this time, we are just focusing on the target. So for theophylline, what is the target? So phosphodiesterase, you see that question in the exam. What is the answer? It is theophylline. Okay, theophylline basically acts on that. Phosphodiesterase. Glucocorticoids, like inhaled corticosteroids, also are trying to help because we have a chronic bronchitis as one of the components. So inflammation is out there, so we can use glucocorticoids. The same thing, we have glucocorticoids on the left side. You can see what happens when there is an insult of inflammatory mediators. And on the right side, we have glucocorticoids, which causes protection. We have inflammatory component like IL-1, TNF alpha. They translocate to the nucleus. They cause dimerization, move into your nucleus to activate all the gene transcription process of those inflammatory cytokines, basically at the level. Then you take glucocorticoids. Glucocorticoids bind to which receptor? Glucocorticoids bind to glucocorticoid receptor called as GR. They bind to this receptor. Is it on the nucleus? Is it in the cytoplasm, or is it on the surface? It is in the cytoplasm. It is below the surface. That's the reason this drug has to be highly lipophilic to penetrate through your membrane, go and bind to the receptor, which translocates, which basically means now the receptor is active. It translocates to the nucleus. It inhibits all the activation of your cytokines, a process called as gene repression. If you cannot remember all of it, then I have two words for you. One is downregulation of pro-inflammatory cytokines. The second process is upregulation of the beta-2 receptors. I discussed this in the previous class, why we have combination of ICS plus SABA, because it causes upregulation of your SABA. Remember, we didn't discuss much in detail about your SABAs. SABAs had a problem. What was the problem? You constantly use it, it causes desensitization and downregulation. That was another question which people got wrong. In the exam, I asked you, alpha-1 receptor desensitization or beta receptor downregulation. What is the correct answer? Please tell me. Alpha-1 receptor desensitization or beta receptor downregulation. I'm using SABA. Alpha-1 receptor desensitization or beta-2 receptor downregulation. What is the answer? How? So if you just say the word desensitization doesn't mean it is correct, right? It doesn't have the right receptor over there. 7 out of 8 students who met me on the other day, they got wrong. Please read the question. That's where, remember and recall. There was no rocket science. You knew the answer was either desensitization. And also tell me, is desensitization different from downregulation? They are all synonyms. They are all synonyms. Again, you go to your Google and try to find out, there may be some difference, but the idea is that those receptors, you constantly stimulate them, they shy away. They go below the surface. And then that way, the drug will no longer be helpful. So when you take ICS, they cause upregulation, or we can call it desensitization. What is the opposite of desensitization? Sensitization. Supersensitivity, so they cause the receptors to upregulate, bind to the receptor, and go on to produce the effect. Interesting? This is the last drug probably which we gotta read, roflumilast. Very prototypical COPD drug. This is your SCR. It basically says that the dialkoxyphenyl pharmacophore, which is your orange, dialkoxyphenyl pharmacophore, that basic ring is most important for its activity. And it also gets metabolized in your body to a roflumilast N-oxide. And remember that these two green, like just roflumilast and N-oxide, they both are active. What it means is when the drug gets metabolized, doesn't mean that it's losing its activity, it's still active. So that's what it tries to sell, is it's kind of like a prodrug concept, but it's not actually a prodrug. What does a prodrug mean? The drug is inactive, it needs to get activated by an enzyme metabolism to become active. Here, it's no prodrug, it's active, and that's active as well. Just so that you understand that you can take less amount of drug and have this working in your body for a long time. Moving forward, everything is on this slide, the mechanism. I'm gonna go through this, and this is probably going to be our last slide as well. If you cannot get this slide, then I have a shortened version here. Did we see this slide earlier, this one? Or did we see that? We had roflumilast replaced by, replacing what? Methylxanthines or caffeine, right? So what does it do? So what's the target here, to be honest? Phosphodiesterase. So remember, we discussed two drugs today as phosphodiesterase as a target. One is methylxanthines like caffeine, and the second one is roflumilast. What happens? Tell the process. Cyclic AMP doesn't get converted to AMP. I don't know why is that missing, but make that AMP. This is AMP, okay? AMP, so cyclic AMP more levels causes, go ahead, decrease myosin light chain kinase, increase potassium efflux out of the cell, leads to less contraction or relaxation. That's one way of looking at it. So if you can see, the whole process over here of roflumilast, it acts on your PDE4. Is that PDE4? PDE4, because there are a lot of phosphodiesterase out there. This causes more cyclic AMP form. Cyclic AMP activates protein kinases. This protein kinases phosphorylates proteins responsible for three things. You highlight that, three important things. Roflumilast is just not helping with your contraction. It also causes inhibition of fibrosis and also inflammation. Like it's a drug which can do three things. What are they? It reduces inflammation, it reduces fibrosis to some extent, which is basically the fibroblast formation around your epithelial cells, and then also relax the smooth muscles. So anti-inflammatory, bronchodilatory, and the last one is whatever it calls fibroblast, like airway remodeling or airway modifier as well. It's trying to help to some extent that not many cells will end up getting fibrotic, which loses its efficiency for gas exchange. That's all I have for you guys. Any questions? What does it mean? It means that you gotta keep reading, okay? Get through the knowledge checks. That's the first thing you will do. Please do some favor for yourself. Go and read as this concept is fresh in your mind. You sleep on it for 2 or 3 days, you come back to it. I'm promising you it's gonna be very difficult. Okay, take some time today for 15-20 minutes, go through the slides again. Come and meet me if you have any questions before it's too late. I'll see you probably on exam review day and then on exam. Okay, thank you. And this is my last class.
For the entire class?